hypothyroidism, you can advance. So we'll talk about just the absolute basic thyroid physiology, the causes of hyperthyroidism, what we do for workup with labs and imaging, and then what do radioactive iodine uptake scans look like with certain etiologies. Just kind of a basic overview. So the hypothalamus makes a hormone called TRH, which is thyrotropin releasing hormone. That tells the pituitary to make TSH, which is thyroid stimulating hormone. Sorry, I'm in the hospital.
Staff alert. 74.
I'll give you a
Staff
second.
alert. 74. Staff alert. 74. Staff alert.
Oh my gosh. Okay, so the hypothalamus tells the pituitary to make TSH, and the pituitary tells the thyroid to make thyroid hormones, which are T4 and T3. In hyperthyroidism, T4 and or T3 are elevated, and the pituitary and the hypothalamus, which are working fine, sense this increase in thyroid hormones, so they suppress their signals. So subclinical hyperthyroidism is a bit different from overt hyperthyroidism. And kind of the way you want to think about it is both of them will have a low TSH, but in subclinical, the T4 and T3 will be normal, whereas in overt hyperthyroidism, they'll be high. The reason I put a little star beside the T3 is that some people can just have the free T3 be high, called T3 thyrotoxicosis. So in primary care, the first thing you want to do when you get an abnormal low TSH is repeat it in about a couple days or a week or so, and get with T4 with the T3 as well to see if it was true hyperthyroidism or if it was just something that resolved on its own. Some definitions. So hyperthyroidism actually means excess thyroid production. So it's actively making extra thyroid hormones. So that doesn't include something called thyroiditis, where the thyroid kind of gets sick and just just spills a bunch of thyroid hormone and then resolves by itself. Thyrotoxicosis is excess thyroid hormone from any etiology, so it includes thyroiditis. Subclinical hyperthyroidism means that the thyroid is intermittently making extra T4 or T3. So when you draw the labs, the T4 and T3 will be normal, but the TSH, the pituitary is sensing that at times the body has too much thyroid hormone, so it suppresses the TSH. Whereas overt hyperthyroidism is where the thyroid is constantly making excess thyroid hormone. And so that you'll see the TSH be low and the T4 and T3 be high. So the main causes of hyperthyroidism are Graves' disease, hot nodules, which is either one nodule called toxic adenoma or multiple, which is called toxic multinodular goiter, or thyroiditis. So Graves' disease is an autoimmune disease where you get antibodies that attack the thyroid and make it speed up. Thyroiditis, like we talked about, is where you get like an IV contrast where it has a lot of iodine, or a viral illness or something like that. And then it just like spills a bunch of thyroid hormone. And then toxic nodules are where you have like focal areas that are making extra thyroid hormone. And the workup, I put it all here. So you want to start with the TSH free T4 and free T3, and start with the antibodies to look and see if they have Graves' disease. So the antibodies are called TSI, which is thyroid stimulating immunoglobulin, TRAB, which is thyrotropin receptor antibody, and then TPO. TPO is technically the Hashimoto's antibody. So that can be positive in a lot of people with autoimmune thyroid disease like Graves' disease. So if the TSI and the TRAB are positive, then you have Graves' disease. If the TSI and TRAB are negative, but the TPO is positive, you can have something called Hashitoxicosis, which is basically when Hashimoto's, you have those TPO antibodies and they start to wear away at the thyroid. And eventually we know that hypothyroid or Hashimoto's patients are more likely to become hypothyroid. But some people develop this Hashitoxicosis where the antibodies are kind of wearing away at the thyroid and creating an inflammation of the thyroid. And it's the thyroiditis. That's why it's called Hashimoto's thyroiditis. But that inflammation can sometimes lead to some leaking of thyroid hormones. So some people will actually go through a hyperthyroid phase. Then they become euthyroid where their levels are normal. Then eventually, as the TPO antibodies continue to tear away at the thyroid, they'll become hypothyroid after that, need levothyroxine. If all the antibodies are negative, then you know they don't have Graves' disease, and you want to get a radioactive iodine uptake and scan. And that's to help us tell if there's hot nodules or if it's a thyroiditis where we don't need to do anything. And you can get a thyroid ultrasound to look at nodules as well. A radioactive iodine scan, I've seen some people get it for like looking for cold nodules, like worried about like thyroid cancer. So the only reason to get a radioactive iodine scan is when someone is hyperthyroid, to distinguish the cause. It's not really helpful to get it for just for looking at like euthyroid patients with regular nodules. And then something optional that I like to do is I also, the first time that I get the labs, I'll get a total T3 and T4, which is the T3 and T4 bound to a protein called thyroglobulin. And the reason for that is that it's kind of like the poor man's radioactive iodine scan. So a total T3 to T4 ratio, meaning the T3 is more or higher than the T4. More than 20 means it's likely endogenous production. So the thyroid is actively making thyroid hormone, like in Graves' disease or hot nodules. Whereas a ratio less than 20 makes you think it's likely a thyroiditis, meaning it's not actively making anything, it just spilled a bunch and then it'll improve by itself. This is what radioactive iodine uptake scans look like. This is kind of a cartoon picture, so it's not exact. But in Graves' disease, you'll see something called diffuse homogeneous uptake, meaning the whole gland lights up because the antibodies don't just pick at certain areas, they attack the whole gland and make it produce extra thyroid hormone. In toxic adenoma, you'll see one bright spot, so one focal uptake and one nodule. In a toxic multinodular goiter, you see diffuse heterogeneous uptake, meaning like little spots are glowing all over the place, but it's not like a smooth all over like Graves' disease. And then in thyroiditis, because it's not actively making thyroid hormone, it just dumped a bunch, the thyroid's not technically working at that time, so you'll see low or no uptake. So for treatment, for subclinical hyperthyroidism, give me 1 second.
Southeast.
I just muted you for those moments, so just unmute yourself when you're ready again.
Sorry, someone's coding over here. I feel bad for them. So for treatment for subclinical hyperthyroidism, not everyone with subclinical needs treatment. So remember, that's where we said the TSH is low, but the T4 and T3 are normal. But you can do treatment if they're, older, like age over 65, cardiac disease like atrial fibrillation or any cardiac disease. If they have history of osteopenia or osteoporosis, because that can increase their risk of fractures and wear away at their bones, or if they even have symptoms of hyperthyroidism and it's really bothering them. And then the treatment will depend on the etiology, and the treatments are the same for overt hyperthyroidism. So for Graves' disease treatment, so overall, there's 3 treatments. It's either medicine, radioactive iodine, or surgery. The absolute best treatment for Graves' disease is actually medicine, because about 30% of patients that are put on methimazole or PTU will go into remission and their Graves' disease will never come back. And then about 30% it'll go away, but then come back later in their lifetime. And about 30% it will never go away. So you either continue it forever or you go to one of the curative treatments, which is radioactive iodine or surgery. So for methimazole, it's the preferred one, and mainly it's because of the dosing. You only have to dose methimazole once a day, but if you get to higher doses, maybe twice a day. Whereas PTU has a shorter half-life. You have to dose it 2 or 3 times a day. So we often see that leads to like poorer compliance or forgotten doses, especially the middle of the day dose, or people are busy or at work. Um, so it's not my favorite, but methimazole is usually preferred because of that. There's very rare side effects that we counsel patients about. So agranulocytosis means a low white blood cell count. So we tell patients like our white blood cells help us fight infection. So if you have like a sore throat that's just not going away after a couple weeks, then you want to let me know so I can check your white count, make sure that's not the cause. Other rare side effects are elevated liver enzymes, or very, very rare is liver failure. So you always counsel them, like if they have like nausea, vomiting, jaundice, like their eyes are turning yellow, their stomach is hurting, then they really need to let you know. The most common side effect, if you're going to see one, is probably a rash or hives. And then if someone gets a rash on methimazole, then try switching them to PTU first. Um, if they don't tolerate methimazole, or if they want a curative treatment or whatever reason, another option is radioactive iodine, which is curative. So because Graves' disease is they're overproducing in the whole gland, so it'll burn out the whole gland, and then they'll be hypothyroid forever. And then you treat them for hypothyroidism with levothyroxine. If they have Graves' eye disease, then if it's mild, sometimes you can still use radioactive iodine, but moderate to severe disease, it's not recommended because it can worsen Graves' eye disease. And even in Graves' disease, if you get them euthyroid, the antibodies can still attack the fat in the muscles behind the eye and make them push forward and cause dryness and stuff like that. So whenever you have a patient with Graves' disease, you want to let them know to let you know if they're having any eye symptoms, so you can refer them to ophthalmology. And then our least preferred treatment, just because we want to avoid a surgery if we're able to, is surgery. So total thyroidectomy, and then you treat them for hypothyroidism. And then before you go for surgery, though, I try to control the levels with PTU or methimazole, because whenever the surgeons get in there and a big Graves gland, it's kind of bloody and vascular, and it can be dangerous for the patient and put them at risk for thyroid storm. So you try to get them as well controlled as possible, and then they go for surgery. Then you can get them off the methimazole or PTU after. For hot nodules, the best treatment for hot nodules is actually the radioactive iodine ablation, because it will target only the hot spots and leave the rest alone. Now, if some people have, oh my God, this hospital. So some people, if they have a bunch of thyroid nodules, they'll probably develop hypothyroidism after, but some people don't. Then you just kind of tell them it's hit and miss. If you're going to develop it, we'll start you on levothyroxine. Some other options for hot nodules are surgery, which is also curative. Methimazole and PTU are not ideal for hot nodules because the hot nodules won't go into remission. You're just controlling the levels. So sometimes people don't want surgery or have some contraindications, like they're elderly or have multiple comorbidities where anesthesia would be dangerous for them, or they don't want radioactive iodine for whatever reason. So in some people, I have used methimazole just for a long time if they just need some low doses. So thyroiditis is where the thyroid gets sick and it just throws up a bunch of thyroid hormone. IV contrast has a lot of iodine in it, and thyroid uses iodine to make thyroid hormones. So that's why some people get thyroiditis after that. Viral illness, trauma, like sometimes if people have like a trach or something, like an emergent trach place, and they're right here and it gets like, smashed, then that can create thyroiditis. But it will resolve by itself. But some people do report some pain, like a subacute thyroiditis, and you can do prednisone for a couple of days. I usually do 40 milligrams for 5 days, or they can just do NSAIDs, and it'll resolve in a couple of days. Propranolol is just an adjunct to any hyperthyroidism. I usually do 10 milligrams TID PRN for symptoms like anxiety, heart palpitations, insomnia, that kind of stuff. I don't like to schedule it. I just let them use it as needed. And then I have a case. So this person is a 30-year-old male, and he recently had the flu. And he had symptoms, including fever, nausea, and vomiting. And then 2 weeks after those symptoms resolved, he developed heart palpitations, excess sweating, anxiety, irritability, and hand tremors. His TSH is a little bit low. His free T4 is a little bit high, and his free T3 is normal. Can you advance this slide? Okay. His thyroid ultrasound didn't show any nodules, and it showed low vascularity. His repeat thyroid labs a week later. His TSH is still low, but improving. His free T4 is normalized, and his free T3 is still normal. So what do we think this is?
Feel free to unmute and or chat.
I don't know if I can see the chat.
I think you're trying to steer us toward thyroiditis, are you not?
Yeah, exactly. Thyroiditis. And yeah, that's it. Yeah, I put my email at the end. If you guys ever have any questions about any of your patients, feel free to email me. I'm happy to answer any questions.
Thank you so much. All right, there we
Sure.
go. Does anybody have any questions? And we do appreciate you putting the case within, but remember, we do like those that can to submit a case, and we are open to help you with that as well. Does anybody have any comments or questions regarding this?
I like very nice, concise, especially about the workup. Because, yeah, now and then you'd get somebody who has a low TSH and elevated free T4. So I guess this is making more sense to me now.
Yeah, sure. Yeah. The most important thing is just to repeat the lab and see which way it's going. There's a good, and thyroiditis can occur in anybody. Sometimes we have these people referred to us for hyperthyroidism where the lab wasn't repeated. And then it takes them like 2 to 3 months to get into our clinic. And then by the time we see them, everything has normalized. Mm-hmm. So definitely I would just repeat the labs. And then if it's still there, then absolutely they need further workup.
What's the optimum time frame for repeating?
I would do it in a week.
Okay, if it changes that fast then.
Yeah, and if you're already seeing the TSH come up, but even if it's still low, but it's coming up, then I would wait like 3 to 4 weeks and just keep watching it over time to see if it just improves. But if it looks like it's like completely suppressed, like the TSH says like less than 0.008 or whatever your lab is, then I would do that one like every 1 week. And if it's still the same, then that person is more likely to have like overt hyperthyroidism. Like I would think more likely Graves or hot nodules.
Okay, so if we've given it a couple weeks, the TSH is still suppressed, then we launch the rest of the workup.
Yeah, exactly.
Okay.
Great questions.
All right, thank you.
How often should someone get their thyroid levels checked?
If they don't have any problems, usually I would do like once a year with their primary care doctor.
Okay, that's good to know.
Yeah, I mean, that's kind of what I do. Of course, we have people who go to a health fair and they'll get the whole thing done. And
yeah,
then we have to figure out what to do with the results. But
yeah, but normally just like preventative, I would just do yearly.
Perfect.
Because it will get paid for with a hyperlipidemia diagnosis by most insurances, even Medicare. So I usually do, we don't have a lot of people that don't have some sort of hyperlipidemia or dyslipidemia. So.
Right, yeah.
So yeah, okay, so once a year is kind of the right thing. That's good to know.
Yeah.
Awesome. Well, if there aren't any other questions, I really appreciate your time today, and thank you so much.
Thank you.
The next session will be on October 26th, and Hugh Quinn is going to be discussing insurance. So I hope you guys have a great couple of weeks, and we'll see you then.
Thank you.
Bye.
Bye.